Hi, I'm Ting, the founder of Little Warriors, and I have with me here Dr. Mohana. Dr. Mohana, do you want to introduce yourself?
Sure, I'm Dr. Mohana. I'm a pediatrician with a subspecialty interest in pediatric allergies, to be particular. And I practice at Petite Practice at Juchet Road.
Both my girls were born with eczema and allergies, and Dr. Mohana is somebody that we trust with allergies, with illnesses, and we come to her whenever we need medical help. Okay, so Dr. Mohana, today we're going to dive into topics of eczema, topics about allergy, and we're going to talk about some things that parents are very worried about. Like, for example, are steroids safe? Is there really such a thing called topical steroid withdrawals? Before that, let's go into a very basic question that a lot of new parents with babies with skin conditions they are worried about. Is there a link between eczema and allergies?
So yes, there certainly is a link. So when we talk about allergies, we usually talk about an atopic march or an allergic march. So interestingly, the earliest form or signs of an allergy comes in the skin as eczema as early as infancy, so the first few months of a baby's life. So it usually starts off in that manner where you're flaking, dry skin, an open barrier of, if you can so say, the immune system to the outside world comes from the skin, and that's usually the first step of allergies. It recently has been more evidence as to why there's a link between eczema and food allergies as well. And this is where the skin barrier hypothesis comes in. And what we know is that intact skin is actually a protected outer layer of skin that protects the exposures into the inside of the body or the immune system as well. But once there's this open barrier of the skin due to eczema, then all these exposures come from our environment as well, right? So it can be from food in the environment, so caregivers eating foods in the surroundings, preparing food in the surroundings, and dust and contact of the food then comes into contact with the naive immune system, right, in the form of the skin through the baby. And these minute exposures to the immune system very early on, prior to adequate exposures through consumption or eating or weaning, actually kind of shifts the body's mechanism to develop food allergies as well.
So, from my experience and from many other moms who share with me, most of our babies start exhibiting signs of eczema around the age of 2 to 3 months. Is that what you are seeing also?
Yes, so specifically in infantile eczema, that does crop up about the age of 2 to 3 months. There are some babies who unfortunately might develop it even sooner.
And the areas are usually quite common, right? And
I must say the first most common area tends to be the face or the cheeks. Yes, the cheeks are usually the first signs of where that occurs. And that pattern of infantile eczema usually happens because the baby is too young to scratch yet, right? And so they tend to be able to have that face exposure, to be able to rub on their own mattress covers or caregivers' clothes. And that's how when they're itchy, they tend to rub more and it inflames more and it starts showing up in the skin of the cheeks first. And then commonly we learn that the other areas of eczema in the infant also come more in the outside areas of your arms or your legs rather than the folds yet that develops as they grow older, also because of the pattern of rubbing, right? So on the outsides of your skin. Although yes, the eczema can occur in many areas, other common areas that I see in clinical practice would be around the neck fold area. So sometimes babies who are a bit chubbier, right, the folds crop in, so a lot of their milk or their drool or even just sweat dries up in those layers and they get really macerated red areas as well, and that triggers the eczema in those areas. And as they grow, yes, they sweat a bit more, and all the other fold areas like the insides of your elbows or behind the knees get affected as well.
So for a lot of our babies that present with rash around the face, people around us, they would say that's milk rash.
Oh yes, I hear that too in clinic. It's always a
Is there
drool
such a thing
rash
as
or milk rash.
drool rash?
I think the most important thing when you see that rash is that you have to be cued into the fact that the skin is not completely normal, right? It is getting irritated. Not every baby that drools or drinks milk develops that rash, right? So It might be a matter of semantics. I usually tell my patients it's what you want to call it, but we know that the skin barrier is broken, and we know there are different forms of eczema, right? So there are perhaps 6 different subtypes of eczema. I usually say the most common thing that starts first is even your cradle cap, and that's what we call seborrheic dermatitis. We know it's a very common spectrum that can also happen in newborns without skin issues, but it cues you in to then just protect the rest of the skin better, because the seborrheic dermatitis or cradle cap can then link or develop into other forms of eczema too. So it just cues you in that, okay, let me protect the skin barrier better, moisturize better, look at the products I'm putting on baby skin a bit more, clean that milk, clean the drool rash a bit more. So if it's purely really around the mouth with no other signs, it's fine to call it a drool rash or a milk rash, because in medical terms we call that an irritant contact dermatitis. So the skin around the face is just getting a bit more sensitive or irritated purely to the contact of the milk and the drool. And yes, that could be certainly there in some babies, but we need to make sure that that baby doesn't also have an atopic dermatitis, right? Then there's more skincare that's needed. It's just that the fact that the saliva and the milk is an aggravating factor and it's worse around the face. But there's also evidence of skin issues in other parts of baby skin as well.
So that's a first sign that we should be cued in, and we should be thinking more about whether there could be underlying issues to just a milk rash.
Yes.
Okay. And the number one question that most of you have been asking is, how do I find out my child's allergies?
Okay, so that's a very appropriate question for me because that's my subspecialization. So in terms of determining a child's allergies, I do think we might always want to be a bit more objective instead of subjective, right? So when we talk about allergies, and if we are talking about younger age group of children with eczema, then it's usually food allergies we're concerned about. Right, so the first sort of symptoms that cue you into a food allergy is actually an acute allergy type of symptom that might occur upon consumption of the food. So that generally happens around 6-7 months. The baby is weaning to solids, and you notice certain symptoms when you're feeding the baby
So
new
like
foods.
throw up, vomiting?
Yes, so the most common symptoms tend to be either skin-related symptoms or gastrointestinal symptoms. Those are the top 2. So when we talk about skin symptoms, that could be acute new red rashes that develop quite soon after consumption of the food, usually within a good 10-15 minutes, but sometimes up to a couple of hours, 2-3 hours after the intake of the food as well. You could also have hive-like rashes. So these bumps that crop up in the skin, which are quite itchy, red, and look like lots of mosquito bites around the body, or a bit of eye swelling or lip swelling, that's also possible. Yes, gut symptoms are also fairly common. So babies may start throwing up or vomiting, or after some time developing some diarrhea as well. Of course, there are severe reactions. Those are very obvious. If the baby turns very quiet, lethargic, right, along with vomiting in this rash, or they start breathing very noisily, wheezing, or having a very noisy upper airway breathing, tearing, red eyes or so. So those are a lot more severe symptoms where more immediate attention needs to be sought as well to deal with the acute reaction before we then work up the food allergies. So when we objectively determine the food allergy, that comes with testing. And these are immediate type allergies, or what we call IgE allergies, when they produce acute symptoms. And the tests which are done to diagnose IgE-mediated allergies are either skin prick tests, which can be done from a very young age in infancy as well, or blood tests is the other option as well.
Okay, we have many parents who are concerned about pricking the skin, and then they are also wondering whether blood tests are more accurate than skin prick tests.
Yes, these are very, very common questions. It's generally described as almost a scratch sensation. We put a bit of an extract on the skin, which is a cold droplet. We do that scratch on the surface with the tip of a needle, and we look for a local reaction, and that reaction is read 15 minutes after the test is performed. I actually do like skin tests a lot because the results are also very visible to the parent. Right, so in that 15 minutes, you can actually see that swell up. You can see what's the biggest one, what's the smallest one, and it's very visible to everyone around, right?
It's
The
very
child.
assuring to have answers directly in front of you. So my
That's
kids
right.
have done skin prick tests. I see for myself, I immediately identify that these are the foods my kids are allergic to and I cannot touch them. Is there a difference in accuracy in terms of the skin prick test or the blood test?
So no, there is no difference in terms of accuracy. Studies have shown they are equally sensitive in that manner. It's just the specificity. So these are a few of medical terms which are different. So that means that when we do blood tests, they're a bit less specific because they may show up with a lot more false positive results, which means that you might have many small positives on a blood test which is performed, which show up as positive, but your child actually does not have that food allergy. So because there is a risk of higher false positives on a blood test, then the interpretation of the blood test in the context of the child becomes very important.
Okay. And I also understand that sometimes you have to do a blood test if the child is covered in irritated skin. So like if the child is covered in eczema and there's no clear skin surface to do the skin prick test, that's when you order a blood test?
Yes, so there are certain instances where we cannot do a skin prick test. One is if your child has needed antihistamines orally, which could be itch medications, runny nose medications, or cough medications, and they can't seem to be off it for a period of time. Generally, they need to stay off these for at least 3 to 5 days before a skin prick test can be performed. As if you cannot find any area of clear skin for that to be done, whether that's on their forearms or the back or so. So if that doesn't seem to clear up, then yes, we would opt for a blood test as well.
Okay, then I move on to the next question that we have. So if you are tested positive in a skin prick test, and when you feed the child the food and you realize that your child has very mild symptoms, so maybe a little bit itching, is that a reason for you to continue offering the food? Will your child outgrow the allergies by continually offering the same food and exposing them to the allergen?
Okay, so this is a very tricky question to answer because firstly, we do not want to compromise safety. And as an allergist, then we have a little bit of a background knowledge as to what might be safe and what might not be safe to then advise a patient in each separate patient's clinical context, right? So the advice I give is not supposed to be applied across every child because firstly, we may not know what the index reaction was for the child, how much they needed to eat to then develop that symptom. But yes, we do sometimes advise certain types of patients to take well and safe amounts of food to continue that in the diet for exposure if they're able to tolerate it. And this concept is because we identify like an allergic threshold, right? So what is the safe point at which the child would not react, would not be at risk of any severe reactions in any way or any reactions in fact, and what they can safely tolerate in tandem with their symptoms as well as what's showing up in a skin test or blood test. This tends to be more the case for the foods which we see more commonly locally as well as in the Asian population. So most of our food allergies in young children come with
dairy,
milk and egg, right? Yes. And what we know specifically for these foods is that the longer we cook it, the higher the temperature that the food is cooked at, the less allergenic. So this might be where that safety of advice of giving either certain forms of baked milk or baked egg products, depending on the child's symptoms, might come in to build that tolerance level to then outgrow the food allergy. So there is specific advice and guidance on this, but it differs from food to food, and it also does differ from child to child.
Okay, so in conclusion, don't offer your child the food on your own. Seek medical help, seek advice from an allergist because it differs from person to person. Then next, we move on to whether eczema and food allergies can be managed through natural methods. And by natural, I mean most of us would try creams. We would go for, like, say, essential oils, traditional Chinese medicine, acupuncture, many different sorts of alternative medicines.
Okay, so I don't really feel that they are alternative medications because medically we also know that the basis of caring for eczema skin is to make sure that it is well moisturized and healed well, right? So in essence, we want to stay away from irritants that aggravate the skin. So if you have a very good wash, a very good moisturizer, which is natural, that is not aggravating the child's skin, then feel free to use that as copiously and as many times as you can to repair that skin barrier, right? So we want to put back what's lacking in the top layer of eczema skin, which is your fat, your cholesterol, your ceramides, and certainly a lot of skincare products or natural products might have that, and that's what we need to use to maintain the child's skin, to reduce the eczema flares as well as to calm it down. Um, Same thing in terms of every child's skin is also different. So different products are suitable in different manners for different children's skin, and you need to find what's suitable and non-aggravating for your own child's skin too. So although essential oils have a lot of natural properties and benefits, we do also sometimes see certain infants or children's skin flare up when they do use essential oil based products, and we then tell them to stay off, to go to plainer products without any fragrances, without any added oils as well. So that advice really varies, and in that sense, it's always important to test the product on the child's skin before then determining if it's causing a flare or helpful for your child's skin, and to proceed on with that. The only advice I have in terms of topicals is to try to stay away from products which have food ingredients in them. So what we have found recently, as we spoke about earlier, the link between eczema and food allergies is the early exposure through the skin barrier to food products, which then set up the child for more allergic response and a higher risk of developing food allergies around the weaning age. So just read the product ingredients and make sure there are no food ingredients such as oat or wheat or almond oil, right, or coconut or so on the skin. Stay on cleaner sort of products and ingredients to repair the skin barrier.
Does it only apply to younger infants who have not been diagnosed with food allergies?
Actually, interestingly, it doesn't. We do advocate a lot more for it in the younger infants because that's where we see a lot of a higher percentage of food allergies develop. But this study actually came out of Japan, where they were looking at adults who are using wheat-based soaps on their face. Adults with eczema on their face were using wheat-based soaps, who then, in adulthood, at the age of 40 or 50, developed wheat allergies. So it can actually happen even though we are consuming foods regularly and at an older age group too.
Wow, so it's that compromised skin barrier and the allergen going into the skin through the compromised
so it's quite
skin
interesting.
barrier.
But that is sort of where that group of studies really first originated on, that spurred everyone to then look into this link of the barrier between the skin and food allergies too. It was actually cropping up in groups of adults in Japan who were developing wheat allergy through using a wheat-based soap.
Wow.
Yeah.
And then I'll move on to a very controversial topic that we want to address. Most of us are concerned about the safety of steroids. We know steroids are effective. Are they safe?
Okay, so another very common question in most patients or babies who come in with eczema as well, right? Because firstly, at a very young age group, we may not want to introduce medications to begin with. And then with steroids, there's also always a little bit of fear about what that might potentially cause. So firstly, with steroids, we know that there is a steroid ladder and also different potencies of steroids as well. So having proper guided use of the steroid is the most important aspect of steroid use, I do feel, right? So in a younger age group, being able to control what is the appropriate steroid potency and duration of use is the most important part of that use of medication in eczema management.
Okay, so we have heard of parents with children with very severe eczema who have been using steroids for years, and it's very hard to wean off steroids when it is the one thing that helps you manage itch and helps to give your child the quality of life. Is it advisable then to keep on using the steroids that the doctors have prescribed?
I think you really have to discuss your treatment plan with your doctor, right? Whether it's your dermatologist or allergist or pediatrician or GP as well. So there needs to be some sort of expectation in terms of what the long-term outcome measure might be. There's been a lot of developments in recent years. So steroid is not the only medication that can be used to control inflammation at this point of time. So there's groups of topicals called tacrolimus or pimecrolimus, which are calcineurin inhibitors. You might know them by their brand names such as Elidel or Protopic, right? So those are also anti-inflammatory medications, but don't have steroid thinning properties. There are also newer products like crisaborole, which is Staquis, that's the other name that it's called by, that are also used for younger babies now from 3 months of age to gain control of inflamed skin. Then there are also the injectables or dupilumab and lots of other, biologics which are coming on in the market, which are able to then control the skin too. So there are many options that you can explore in discussion with your doctor as well. The most important thing I feel if you're on long-term steroids is to keep your follow-up visits with the doctor to then assess if there is any side effects from your topical steroids being used long-term, such as thinning, redness, right, new capillaries, telangiectasias, and to have sort of a weaning or dropping plan. So of course, although topical steroid withdrawal isn't mainstream or common, but we do know there are some severe cases which then scare a lot of parents, whether it's children, parents, or adults. But it probably shouldn't be a blanket fear. And what we do know in terms of evidence is that the higher potency you use for a longer period of time, and perhaps in thinner areas, more sensitive areas like your face, your groin, would then predispose you to these sort of withdrawal symptoms, although they are rare, right? So it's overall guided by the duration and potency of use, and that's important. And you would need to be aware that there are alternative options to steroids.
And I also hear from you a lot that other than using medications to control the inflammation of the skin, we have to look for the root cause and we have to investigate further what could be triggering the eczema.
Yes, and that's not an easy process either, right? Because eczema is just purely so multifactorial. So I have patients coming in telling me, okay, so eczema is an allergy, right? So I need to have an allergy because eczema is an allergy. But that's where there's a little bit of an issue because eczema, although we classify it into a group of allergies, is in basis a skin barrier defect. It's not by definition an pure allergy causing it. Yes. So we know it's multifactorial because it comes with anything that's irritating your skin, right? Your clothing, fibers, the environment, heat, sweat, too dry, too hot. Many factors aggravate that, right? You go to a hotel room, it's dustier in the carpet, the eczema flares. In addition to things that happen in your immune system internally, which you can't control. Whenever you fall sick, when you need to get your vaccinations to protect you, that could also flare up your eczema during periods of time. Yes, there are certain children where allergies do contribute to eczema, but no, not all children with eczema do have allergies as the main contributing factor or only contributing factor. So that's where it gets a little tricky. And because eczema comes in waves, right? It goes through cycles, periods of quiet and periods of flare. It gets very confusing, especially to parents of infants who are then very early on in the eczema journey or just about exploring foods and weaning. They get very fearful of every small change that coincides around a period of flare. And that's where sometimes we see lots of unnecessary food avoidance. In effect, when you look at long-term studies of big groups of children or infants who do have eczema, only about 20% might have a concomitant food allergy. So 80% don't and 20% do, right? So for that 20% where we can identify the allergens and that's one of the contributing factors which you need to stay off, then that would be helpful as one of the aspects of many of the factors that can flare eczema. Yeah.
So I always tell other newer eczema families that eczema is a marathon. It's not a sprint. I know that we are so desperate to look for solutions for our kids. We are desperate to look for a cure, but unfortunately, there is no one miracle cure out there for eczema.
You're right, it's a marathon. For some, it's shorter than others
Mhm.
because although infantile eczema is really quite stubborn, it's very hard to deal with, it's repeatedly being aggravated in short periods of time. Many of the infants that I do see do get better over time, right? So somehow the immune system tends to settle, the skin gets a bit better. They get a lot better past one, close to the age of 2 or 3 as well. Quite a good number do outgrow it as well. So although it seems dark days early on, it really does get better over time for a majority of them. So of course, some then continue on into childhood to still have signs of eczema. But over time, a large majority do get better and better. It doesn't seem to be as severe. The flares don't seem to be as frequent as well. They seem a lot more manageable too.
And as you grow up with your child, you also can identify the triggers better. You know how to better manage your child's lifestyle, food, triggers, what to do whenever there's a flare,
That's right.
and what to do to avoid flares.
Yeah. I think it's important not to try to pin the cause of eczema to anything particularly, right? So, as an allergist, I see a lot of patients that come in really banking on the fact that it might be food. And if they can exclude this, and this, then the skin would be better. And we tend to get disappointed when it doesn't, because by effect, we need to be focusing on many aspects of eczema: the skincare, the routines that we put in, right? How we reduce the itch scratch cycle, reducing infection as well, looking at the environment, the temperature, and lots of aspects of that. So while we do have a small number of patients where food allergy indeed was the main trigger and cause of eczema, like we said, the percentage is not high. So that's not going to be the answer for every parent with eczema, and that shouldn't be placed in the minds of everyone, right? The false hope that maybe it's a food and that will be the answer to the skin as well. Yeah.
Okay, so for parents who are already in the trenches, in the deep trenches of eczema, if they are already being prescribed steroids by their doctors and they are fearful, they're worried about what the use of steroids may potentially impact their child, what would you advise them?
So I think firstly, I think it's important to be really open with your doctor, to have a good relationship with them and an understanding. Yes, I see a lot of parents take that steroid tube and then they keep it at home and then they tell me, oh, I just haven't used it, right? So there's no open discussion in terms of what your fears are or what your preference might be as well. Many doctors may be open to that, but if we don't know what those thoughts are, then they cannot be addressed during the consultation
Mm.
as well. So it's important to try and think through why you're fearful about steroids and share that with your doctor. Is that certain aspects you've read about? Is that certain symptoms, or the fact that you think that your child may be on that long term? Or perhaps you just need a discussion about what the alternative medications or routes are, and have a treatment plan, right? Whether it's with medication or not, it's still a treatment plan. So if you are doing just skincare or going naturally, then at what time point you need to seek attention, right? Or perhaps a doctor comes into an agreement with you on, okay, let's review you in a month and see how your skin is doing with this plan that we have, and then we can make a decision together on whether we start medications for the skin or not.
And I also hear you speaking about safe weaning of medications. Can you tell me more about that?
Okay, so weaning is not a one size fit all,
Mm.
which is why I think it's very difficult to put out a standard protocol,
Mm.
right, for weaning as well, which is why it's very important to then work with your doctor. Firstly, if you feel that based on your doctor's prescription of the steroid or medication, that the skin firstly is not improving
Mm.
along what was prescribed, right? Within that 5 days or a week, you don't see any signs of improvement, it's important to go back and check back in. Or secondly, if you feel that there's improvement, but hey, I've been on the steroid for 2 or 3 weeks and it's very slow, gradual improvement, right? And thirdly, if you come off the steroids, but in 2 days or three, you find that, oh, there's a flare up, I need to go back on steroids. Of course, we know steroids help and that will clear the skin in majority of cases, but then because it helps, there will be flare ups back to a state of flare up if we don't remove or change anything about the inflammatory process otherwise, other than using the medications. So if you find that there's a repeated and frequent need of going back onto steroids to then calm the inflammation, that's about time you check in with your doctor again. Because firstly, we may want to identify other cofactors for inflammation that we can help to treat to then reduce the need for steroids or steroid spare by using other non-steroidal inflammatory medications as well. Yeah, so it's a very common problem because we have patients then emailing in, yes, my skin has cleared, but 3 days after stopping steroids, there is a rash again. Shall I just start my medicine again, right? But that's not a long-term solution. And yes, that is where it should be guided, especially in terms of if you've used a more potent cream, when to come down to a less potent one, and the duration of usage as well. That should be guided by the doctor, who then objectively assesses the skin and improvement and duration and flare-up periods, and together working with them come up with a acceptable medication plan for your skin.
I love that you have this advice. And then if I move on to advice for parents who already have kids with eczema and they are thinking about having more children, is there any advice for having preventive tips for a second, third child to prevent eczema?
Yes, so we know that if you have a parent or sibling with eczema, then your risk of developing eczema is extremely high, almost a good 60 to 80%. And we talk about prevention, then it's preventing also the whole group of allergies, not just eczema, but how can we then prevent maybe food allergies or asthma or allergic rhinitis as well. So we can break this into a pregnancy phase as well, a delivery phase, as well as the early infancy phase. So within pregnancy, the most important thing would be to have a very good, nourishing, what we call a Mediterranean diet. So a diet that's very high in fruits and vegetables. That's found to help reduce a little bit of the risk of developing allergies, whether it's eczema or food allergies or asthma or allergic rhinitis too. We also want to have a very balanced diet with all our allergens in, unless of course the mom has specific true allergies, then she will need to avoid that allergen for her own health needs. But otherwise, please continue with all the allergens in pregnancy. What's also found to be helpful is if you already have a pet in the household, please keep the pet there during your pregnancy and the early years of the child. So living with a cat or a dog in the household, even during conception as well as postnatally, has been shown to reduce the risk of allergies in babies and children as well.
So the more you are exposed to allergens while pregnant, the less likely that your child might
That's
develop
right.
allergies.
Yes, that's right. And then we come to the sort of delivery phase, right? So the mode of delivery has been shown to be very important. So as long as it's safe, opting for a normal vaginal delivery is very helpful in reducing the risk of allergies. Of course, if there's a help to the mom or to the baby for safety issues, sometimes cesarean sections are needed, and we shouldn't say no when it comes to life, right, or life-saving measures. But otherwise, if there's an option, always opt for a normal vaginal delivery instead of an elective cesarean section with a family history of allergies. We also try to reduce the use of antibiotics. In the perinatal period, there are certain indications where antibiotics may be needed. For example, in group B streptococcus mummies who are delivering in a normal vaginal delivery method, they might still require antibiotics. But otherwise, if you're not too unwell, you're just having viral colds, try to avoid the use of antibiotics. And this extends into the first 6 months of babies' lives as well. So trying to prevent the early use of antibiotics in the infant also reduces the risk of developing allergies. Probiotics is something that has been explored in terms of prevention. So there has been some evidence that using certain specific probiotics, such as the strain called Lactobacillus rhamnosus GG, and in high enough colony forming units, so at least 10 billion colony forming units a dose, daily from the third trimester, so from 36 weeks gestation onwards, and continued on for the infant for the first 6 months of life, may be preventative in reducing the risk of eczema.
So early exposure to allergens while the mom is pregnant, and then high doses of probiotics might, it's not guaranteed, but
it's not guaranteed, but it's the best that you can do to try your best to reduce the risk of allergies. The last point would be early moisturizing with a safe moisturizer from delivery moving forward, right, for the first 6 months of life. So using a fragrance-free, good moisturizer with good cholesterol, fats and ceramides onto baby skin quite soon after birth as a daily routine. Yeah, even when the skin is normal, to protect that barrier that might be predisposed to developing eczema for the first 6 months of life, has been shown in some studies to reduce the risk of developing eczema to as high as levels of 50%. So that's worthwhile trying.
So the final question as I wrap up would be for parents who already have children who are struggling with their skin, how should they go about getting a proper diagnosis for their kids, whether is it an allergy, is it eczema, is it a rash, is it something they should be concerned about? What should they do?
So if any doubts about what's going on in your baby's skin, then always check in with a doctor, because you usually would need a medical diagnosis from a professional who is experienced enough in looking at many baby skins or be able to make that diagnosis. I know in this day and age, there's a lot of internet and Google and hearsay sometimes, so it gets very tricky. Because even if we Google a certain picture or a diagnosis, many pictures can look fairly similar, and it gets tricky with trying to do a self-diagnosis or looking at Dr. Google. So do seek friendly medical advice from your doctor as well to make a diagnosis for the skin and to receive medical advice on how to then manage the child's condition.
All right, perfect. So Dr. Mohana is with Petite Practice, and Petite Practice is at...
It's at 467C Juchet Road. It's
and
at
how can they
Katong.
contact you?
They can find me either on Instagram. My Instagram handle is Dr. Mohana Raja, or we have a website through which it's very convenient to book appointments for allergies or well visits, or we also see sick visits as well, and that's www.petitepractice.com.
And if you're looking for emotional support, you're looking for families who are in the same boat as you can follow Little Warriors. And I'm here to cheer you on. Thank you.